Welcome to the deep dive. Today we're tackling something really common, a health issue that, well, many adult women will likely face at some point.
Yeah, we're talking about acute simple cystitis.
Which sounds medical, but basically it's a bladder infection, right? The kind that's just staying put in the bladder.
Exactly,
Yeah.
not spreading. And we've really gone deep into a medical review from Up to Date for this.
Right, and it's super current info updated just this month, April 2025.
So our mission today really is to break this down. What is it? How do doctors spot it? And what are the key things to think about for, managing it well?
We want to give you the essential info without you getting bogged down in, super complex stuff.
Okay, so acute simple cystitis. Let's unpack that simple part.
Yeah, sounds good, but what does it actually mean in this context?
It means it's a UTI, a urinary tract infection, specifically in the bladder of an adult woman.
Yeah.
And crucially, no signs it's moved beyond the bladder.
Okay, contained. So it's different from, say, a kidney infection.
Totally different. That's pyelonephritis, a more serious thing.
Hmm.
Or what we call complicated UTIs, which might involve other health factors or structural issues.
And those need a different kind of management plan, yeah.
Definitely. Often more involved. Simple cystitis is, simpler to manage generally.
Okay, so how does this infection typically get started? Where did the bacteria come from?
It usually starts with bacteria that normally live quite happily in your gut.
Like E. coli and friends.
Exactly. Sometimes these bacteria can colonize the vaginal area.
Migrate, sort of.
Yeah, migrate. And because female anatomy has a shorter urethra, that tube carrying urine out, it's a relatively easier journey for them to travel up into the bladder.
Ah, okay. That anatomical difference is key then.
It's a major reason why cystitis is so much more common in women than men.
Makes sense. Are there other things that make someone more likely to get it beyond just anatomy?
Oh, for sure. There are known risk factors. Some might even surprise you, and some are things you might be able to modify.
Oh, interesting. Like what should people be aware of?
Well, recent sexual intercourse is a pretty well-established risk factor.
Okay, heard that one before.
Also, a history of UTIs. If you've had them before, unfortunately, your risk is higher for future ones.
Right, that cycle.
And here's one maybe less known. Using spermicide-coated condoms or diaphragms with spermicide or even spermicide alone.
Really? Spermicides. How do they connect to a bladder infection?
It seems spermicides can sometimes disrupt the natural balance of bacteria in the vaginal microbiome.
Ah, okay. So messing with that balance gives the bad bacteria, the UTI-causing ones, a better chance.
That seems to be the thinking. A healthy microbiome is protective. We should also mention things like diabetes, especially if poorly controlled, or urinary tract abnormalities can increase risk too.
But today we're focusing on the simple cases, right, where those complications aren't the immediate issue.
Exactly, assuming no major underlying structural problems or uncontrolled conditions causing it.
Got it. So who are the usual suspects then, bacteria-wise? You mentioned E. coli.
Yeah, Escherichia coli is the main player by a landslide. We're talking like 75 to 95% of these simple cystitis cases.
Wow. That's almost always E. coli then.
Pretty much. Comes from the gut, makes its way up. Makes sense.
Are there any others we see?
Less often, yeah. You might see things like Klebsiella pneumonia, Proteus mirabilis, maybe Staphylococcus saprophyticus.
Okay. But mostly E. coli. Does it matter if someone's been on antibiotics recently, maybe for something else?
Ah, good point. Yes, it can. Recent antibiotic use or even recent healthcare exposure, like a hospital stay, can broaden the possibilities.
How so?
You might see less common bacteria, or importantly, bacteria that are resistant to some antibiotics.
Ah, resistance. That definitely complicates things.
It does. That's why in those situations, getting a urine culture to know exactly what bacteria you're dealing with and what it's sensitive to becomes much more important.
And we have to mention the general rise in antibiotic resistance in E. coli, don't we? It's a big concern.
A huge global health concern. It means some of the antibiotics we used to rely on might not work as well anymore.
So doctors really need to be up on local resistance patterns when they choose a treatment.
Absolutely critical. Okay, let's get to the symptoms. How do you actually know if you might have cystitis? What does it feel like?
Yeah, the telltale signs.
Yeah.
What should you look out for?
The classic symptoms are usually pretty distinct. First, dysuria.
Which is there?
Painful or burning urination, just discomfort when you pee.
Got it. Ouch.
Then, urinary frequency, feeling like you need to go all the time, much more often than your usual.
Okay, constant trips to the bathroom.
And urinary urgency, that sudden, intense need to go right now, like you can't hold it.
Right, that feeling of, I need to find a bathroom immediately.
Exactly. And finally, suprapubic pain. That's pain, pressure, or discomfort down low in the abdomen, kind of above the pubic bone.
Okay, so pain when peeing, going often,
Yeah.
needing to go urgently, and lower belly pain seems pretty miserable.
It really can be. And sometimes hematuria blood in the urine can happen too. That can be alarming, but it is fairly common with cystitis.
Good to know. What about older adults? Are the symptoms always the same?
That's an important point. Sometimes in older adults, the symptoms can be a bit less typical, or they might overlap with other chronic urinary issues they might have.
So what's more reliable then?
In that group, doctors often look for the acute onset, like a sudden start of dysuria or maybe new or suddenly worsening urinary urgency. Those are often better clues than just, say, chronic frequency.
Okay, that's a helpful distinction. And what about things like cloudy urine or smelly urine? Does that automatically mean UTI?
Not necessarily, that's a common thought, but
Mm.
things like your hydration level or what you ate can affect urine appearance and smell.
So cloudy or smelly urine alone, without those other classic symptoms like pain or urgency, doesn't automatically equal infection needing treatment.
Correct. You generally need those typical urinary symptoms to point towards cystitis.
Okay. Now, when should someone be really concerned? Are there red flags that mean this might be more than just simple cystitis?
Yes, definitely. These are important. Signs suggesting a more complicated infection, possibly involving the kidneys, include a fever usually defined as over 99.9 Fahrenheit or 37.7 Celsius.
Okay, fever's a big one.
Also, chills, shaking chills, feeling really unwell, like significant fatigue or malaise beyond just the bladder discomfort.
More systemic symptoms then.
Exactly. And then flank pain, pain in your side, sort of below the ribs and towards the back, or what doctors call costovertebral angle tenderness.
Cost of what now? Where's that?
Costovertebral angle tenderness. It's basically tenderness over the kidney area on your back. If a doctor gently taps there and it causes significant pain, that's a big red flag.
Why is that specific spot so important?
Because it directly overlies the kidney. Tenderness there, especially with fever or chills, strongly suggests the infection might have ascended from the bladder to the kidney's pyelonephritis.
Which needs a different, more urgent approach.
Absolutely. Different evaluation, often different antibiotics, maybe longer treatment.
Okay, so classic lower urinary symptoms. Likely simple cystitis.
Yeah.
Fever, chills, back flank pain, those red flags, get checked out properly.
That's a good summary.
So how does a doctor usually figure it out for sure if someone comes in with those classic symptoms?
Well, if you have those classic symptoms, the dysuria, frequency, urgency, suprapubic pain, the diagnosis of acute simple cystitis is often pretty likely just based on that clinical picture.
So you don't always need a urine test right away.
Not always, especially if you've had UTIs before and the symptoms feel exactly the same. The likelihood is very high.
Kind of like if it walks like a duck and quacks like a duck?
Pretty much. But if it's your first time experiencing these symptoms, or if they're maybe a bit atypical, then urine tests are definitely helpful to confirm things.
Okay, what tests are we talking about?
Usually a urinalysis and sometimes a urine culture.
What's the difference? What are they looking for?
Urinalysis is a quicker test looking for signs of inflammation and infection, like pyuria, that's white blood cells in the urine. It shows your body's fighting something.
Okay, signs of a battle.
Exactly. A urine culture takes longer because they actually try to grow bacteria from the urine sample in the lab.
Ah, to identify the specific culprit?
Precisely. It identifies the exact bacteria and, crucially, they often do sensitivity testing alongside it.
To see which antibiotics will work against that specific bug.
Yes, what it's susceptible to and what it's resistant to.
What about those dipstick tests you can sometimes do at home or in the office? The ones for leukocyte esterase and nitrite.
Yeah, those can be useful as a quick screen. Leukocyte esterase suggests white blood cells, and nitrite suggests certain types of bacteria are present. But they aren't foolproof. Especially if you have strong classic symptoms, a negative dipstick doesn't completely rule out a UTI, and a positive one just supports what the symptoms suggest. The urinalysis and culture are more definitive.
So when is getting that urine culture, the one that identifies the bacteria and sensitivities, really essential?
It's most important for people who might be at higher risk for complications or resistant infections.
Like
People with underlying urologic issues, maybe kidney stones or structural problems, those with weakened immune systems, people with poorly controlled diabetes, or if symptoms are atypical, or if initial treatment
Or
failed.
if you've had resistant infections before, presumably.
Absolutely, or recent antibiotic use, like we mentioned.
Hmm.
In those cases, knowing the specific bacteria and its sensitivities before starting treatment, if possible, is really ideal.
Okay, that makes sense.
Hmm.
Are there other conditions that can feel like cystitis but aren't? Things that could be mistaken
That,
for it?
yes, the differential diagnosis is important. Other things can cause similar symptoms.
Like what?
A vaginitis, like yeast infections or bacterial vaginosis, can sometimes cause external irritation that feels like burning with urination. Urethritis, an inflammation of the urethra itself, often from STIs. Also, painful bladder syndrome or interstitial cystitis, that's a more chronic condition. And sometimes even pelvic inflammatory disease can have some overlapping urinary symptoms.
So it's not always straightforward, which is why seeing a healthcare professional is important for the right diagnosis.
Exactly. Getting the diagnosis right leads to the right treatment.
Okay, let's talk treatment then. Assuming it is diagnosed as acute simple cystitis, what's the usual approach?
The mainstay of treatment is antibiotics.
Right. And the choice depends on.
Primarily on local antibiotic resistance patterns and individual patient factors. We want to use something likely to work against the expected bacteria, usually E. coli.
So, for someone without major risk factors for resistance, what are the typical first choice antibiotics?
The common first-line agents include nitrofurantoin,
Okay.
trimethoprim sulfamethoxyl, which most people know as Bactrim or Septra,
TMP, SMX, yeah.
phosphomycin, which is often a single-dose treatment,
Yeah.
and another one called pivmecilin, though that might be less available everywhere.
And these are usually pretty short courses, right?
Yes, that's a key point for simple cystitis. For example, nitrofurantoin is typically given for 5 days. TMP-SMX is often just 3 days. Phosphomycin is a one-time dose.
Wow, just 3 days or even one dose. Is that really enough? With resistance being a worry.
For uncomplicated cystitis, studies show these short courses are generally very effective, and using shorter courses when appropriate actually helps reduce the pressure that drives antibiotic resistance. Longer isn't always better here.
Okay, good to know. So how does a doctor choose between those first-line options?
It depends on a few things. Patient allergies, obviously. Any history of UTIs and what worked or didn't work before. Known resistance patterns in the local community, this is really key. And potential side effects or interactions with other medications.
So it's a tailored decision.
It should be. The guidelines often suggest favoring nitrofurantoin or TMP-SMX when appropriate and feasible over phosphomycin or pivmecilin in many standard cases, but local data is crucial.
What if none of those first-line drugs are suitable? Maybe allergies or known resistance?
Then we look at alternative agents. This might include certain oral beta-lactams, like some cephalosporins,
Okay.
or fluoroquinolones, like ciprofloxacin. However, fluoroquinolones are generally held back.
What is that?
Several reasons. Increasing resistance rates to them, plus they have a higher potential for certain side effects, some of which can be serious. So they're usually reserved for when other options really aren't suitable or for more complicated infections.
Makes sense to save the bigger guns when possible. Now, what about for those people who do have risk factors for resistance? You mentioned getting a culture first.
Yes, ideally get the urine culture and sensitivity testing done before starting antibiotics if you suspect resistance is likely.
And what do you do while waiting for results? Or what if you can't wait?
Sometimes empiric treatment is started based on past results or likely pathogens, but the choice might lean towards agents that have broader coverage or are known to be effective against some resistant strains. Interestingly, nitrofurantoin and phosphomycin sometimes retain activity even against some multi-drug resistant E. coli.
So even with resistance concerns, some first-line options might still work.
Potentially, yes. It depends on the specific resistance profile, which is why the culture is so valuable in those cases.
Okay. Antibiotics are clearly key. Is there anything else people can do, maybe for the symptoms, while waiting for the antibiotics to work?
Yes, for the painful urination, urinary analgesics can help. The most common one is phenazopyridine.
The stuff that turns your urine orange.
That's the one. It can provide pretty quick relief from the burning and urgency, but it's important to remember it only treats the symptoms, not the infection itself.
So don't rely on it instead of antibiotics.
Absolutely not. And it shouldn't be used for more than a couple of days, usually, because it could mask symptoms if the infection isn't actually getting better with the antibiotic.
Good point. And what about people with underlying issues like bladder problems? Is their management different?
For those individuals, yes, the approach might be different. There's often a lower threshold for considering the infection potentially complicated. Needing closer follow-up, maybe imaging, and addressing the underlying issue is part of the long-term plan.
Right, treating the whole picture.
Yeah.
Okay, so you start the antibiotics, maybe take the analgesic for a day or two. What happens next? Do you need to go back for a follow-up test to prove the infection's gone?
Usually, no. For acute simple cystitis, if your symptoms resolve completely with the antibiotic course, a follow-up urine test or test of cure isn't generally recommended.
So if you feel better, you're likely good to go.
In most uncomplicated cases, yes. However, follow-up is needed if things don't go as planned.
Like if.
If your symptoms don't start improving significantly within, say, 2 to 3 days of starting the antibiotics, or if they improve but then come right back shortly after you finish the medication,
What happens then?
that definitely warrants going back to your doctor. They'll likely want to repeat the urine culture, maybe check sensitivities again, and potentially consider imaging tests to look for underlying problems like kidney stones or structural issues that might be complicating things.
Okay, so monitor your symptoms, and if they don't clear up or return quickly, seek further evaluation.
Exactly.
This has been incredibly clear. So just to wrap up the main points, acute simple cystitis, super common in women, usually caused by E. coli. Classic symptoms are pain, frequency, urgency, lower belly ache.
Right. Usually treated effectively with a short course of first-line antibiotics like nitrofurantoin or TMP-SMX, chosen based on local resistance and individual factors.
And crucially, recognizing those red flags, fever, chills, flank pain, that suggests it might be more complicated and needs more urgent attention.
That distinction is key. Simple versus potentially complicated.
Thank you. This really helps demystify it all.
Happy to help clarify.
And for all of you listening, we hope this deep dive gave you a clearer, more practical handle on acute simple cystitis. You know, it really shows how even common conditions have these important details that doctors consider for the best care.
It underscores being aware of your body, right? And seeking advice when symptoms are concerning.
Definitely. And maybe a final thought to leave you with. While we covered the basics of management, if you find yourself dealing with UTIs frequently, it could be really valuable to have a deeper conversation with your doctor, specifically about local resistance patterns in your area, or perhaps more tailored preventative strategies.
Good point. Personalized advice is always best for recurring issues.
Just remember, everything we discussed today is based on that expert medical consensus from UpToDate, current as of March and updated this April 2025. Thanks for joining us on the Deep Dive.